So my goal is, if you've made it to here, you deserve to learn everything you need to know about antiarrhythmic drugs. So I'm going to try to, in 30 minutes, to tell you all that's needed to be known for AADs. Treatment with antiarrhythmic drugs in general, a lot of people think it's kind of a mousetrap. Every move that you try to make, there's a lot of complications. Some people even call it chemotherapy for the heart, which is, at times, it's a reasonable analogy. But if you really want to understand how these drugs work, you really have to understand how the action potential works, how cardiac arrhythmogenesis works. So before we talk about the different mechanisms of arrhythmias, why don't we actually figure out how is a heartbeat generated? So I am going to, So we all have heard and remember perhaps the action potential. So I'm just going to do a correlation between what we see on the surface ECG and the ventricular myocardial action potential. So this is not his Purkinje system, this is not part of the conduction system, this is actually myocardium itself. So the myocardium at rest, the internal intracellular aspect of the myocardium is more negatively charged relative to the extracellular, to the outside surface of the cell. Why is that? There's three reasons, but in a nutshell, it's because of an energy-dependent process using ATPase channels. ATPase channels, it's an exchanger. It uses ATP to exchange sodium for potassium. And that, it kicks out the sodium and it brings in the potassium. So that's why extracellular sodium is higher than intracellular potassium. And conversely, extracellular sodium is higher concentration than intracellular sodium. So what all this adds up to is that at your resting state, without electrical stimulation, as I said, the inside of the heart is more negative relative to the outside of the cells, of the myocardial cells. So what are we looking at here? This is a single heartbeat. Where does this heartbeat come from? It comes from, this is probably the most important slide, and I'm going to spend quite a bit of time on this one. So first thing we notice, x-axis, y-axis. What's our x-axis? Our x-axis is time. What's our y-axis? It's voltage. But it's not just simple voltage. It's voltage of the intracellular relative to the extracellular component. So remember how I said the inside of the cell is negative relative to the outside of the cell at rest? Well, that's what we have here. Minus 90 is the resting membrane potential. That is the situation where the heart is at rest. It's not electrically activated. So we just said that you're kicking out sodium and you're bringing in potassium with that ATPase ion channel. So what that means is the inside of the cell is negative. We just discussed that. And it's negative because of reasons that we're not getting into right now, but it involves the Nernst equation and all those things that we learned in high school. But just remember that fact. In its resting state, a healthy cell, the intracellular space is more negative than the extracellular space. So if you open an ion channel and you give it a chance to actually go through the membrane itself, the plasma membrane itself, if the external space is now more positive and the internal space is more negative, the external space you have more sodium, the internal space you don't have as much sodium because of that ATPase. What happens when suddenly you open an ion channel specific for sodium? There's a rush of sodium to go from the extracellular into the intracellular space because the voltage and the concentration gradients, both of them, the negative of this intracellular of the cell pulls in the sodium, and also there's less concentration of sodium in the cell. So you have two things driving the sodium into the cell. And this single event leads to triggering of the action potential, and that's what your heartbeat is. Once the sodium goes inside the cell, obviously because the sodium is now positive. Remember, sodium is positive, potassium is positive. So when sodium goes inside the cell, the inside of the cell becomes more positive. It goes from negative 90 and it overshoots to about 50. Okay, so now the inside of the cell is more positive. Why is that? Because sodium just went from the outside of the cell to the inside of the cell, so the voltage correspondingly goes up. So positive current going inside the cell in the form of sodium is the trigger and the genesis of your ECG, of your QRS. Your QRS, not your QT, but your QRS is furthermore determined by the slope of this phase 0. And furthermore, myocardial conduction velocity is determined by this slope, phase 0, both in atrial and ventricular myocardium, not the conduction system. Okay, so if you truncate or if you affect this phase 0, remember, what's going to be affected? Your QRS width. Phase 0, QRS width, and anything that manipulates that will affect the QRS itself. And we just said, what is phase 0? It's inward sodium current. So far so good. Inward sodium current goes in. You have the initial phase of the action potential. Then you've now depolarized, and now you're having a cascade of events that is going to end up with calcium going into the cell, as Dr. Afshar was talking about, to then actually start contraction of the heart. So what happens is, once sodium goes inside, you have ion channels that are opening. They're called transient outward ion channels. They're mostly potassium and sodium type ion channels. That causes now, you had initially everything here is positive current going in. At this moment, now the cell is going to make up for that and kick out positive current that had just come in, right? This is how you depolarize by activating the cell, and you're increasing the intracellular voltage. Now you have to repolarize. You have to fix that. You have to reverse that. And so that process starts with potassium and sodium now going out of the cell. Potassium has positive current, and so when your positive current leaves the cell, what happens now? This is going to go up or down. You're going to come back down here because you're losing potassium, you're losing positive current, and the inside of your cell is becoming more and more negative. So when you open potassium cells, the voltages start coming down, and you start going back to where you started, which is repolarization process, and you're ready for the next heartbeat. So far, so good. Between this phase, where the sodium is coming in and the potassium getting kicked out to repolarize you, you actually have the calcium coming in. This is the calcium that's coming in to give contraction to the heart, to give you the heartbeat. This is a sodium-calcium exchanger. It's not energy dependent. It's not ATPase dependent. And then at the end of the day, there's all these potassium channels open. Potassium, remember, inside of the cell has a higher concentration of potassium, and after the sodium is now inside the cell, the inside of the cell also has more positive current. Both of these features act to now kick out potassium because the inside of the cell has become more positive, so positive repels the positive potassium current, and the concentration of potassium is higher inside the cell than outside the cell, so the concentration, the chemical gradient, also kicks out the potassium. Good? So that's repolarization. That's normalization of electrical activity. On top of that, we should remember that there's a period here, it's called our refractory period. The sodium currents, which are responsible for everything starting, after they open for about 50 milliseconds, then they slam shut. And it does not matter what you do. They will not open up again. And this is what we call the refractory period. You pace on the QRS, you're not going to have any stimulation. That's what the impulse dynamics technology is doing. So this is now where we go back to our repolarized state. Any remaining calcium that was inside the cell is removed via the sodium-calcium exchanger, or I'm sorry, the sodium is removed via the sodium-calcium exchanger, and you come back to your baseline repolarized state. So this is myocardium. This is ventricular tissue. Atrial tissue is similar. There's some subtle changes, and we'll talk about that. Nodal tissue, the sinus node, and the AV node, the only real thing, the big difference is that the large current is the calcium current for the AV node for sinus node. But more importantly, what you're depending on is a continuous and gradual depolarization. You see here, between heartbeats, it's completely flat. Here, between heartbeats, these ion channels are still going. And for our purposes, let's just focus on this IF. It's the I funny current, and it is both calcium and sodium exchanging and going inside the cell. And it's a decay of a potassium current, too, at the same time. What that causes automatically is the current is coming inside the cell, just like we said, just similar to this, just not as rapid or as robust. So the inside of the cell becomes more positive until it hits a trigger level. And once you have a trigger level, once you've hit your trigger potential, your threshold, as they call it, then the calcium channels open up again. The calcium rushes inside the cell, contraction occurs, and that's how the process. So this is the nodal tissue, sinus node, atrioventricular node, not the myocardium. So far so good, right? Because these are the two fundamental things that we need to understand. And once you understand this, one last concept, and then things are going to be good. So arrhythmias, the vast majority of arrhythmias are what we call reentry. It's a dog chasing its tail, and it goes around and around. So for you to be able, if the dog's head catches its tail, for our purposes, and bites its tail, the circuit is shut. It's out. Why is that? Because that means that the head of this wavefront has hit refractory tissue. I'm going to call this the orange refractory tissue, the light orange relatively refractory tissue, and the white excitable tissue, because the wavefront has gone all the way around, so anything that was more recently activated, such as at the tip, is more refractory, that the sodium channels are still not going to open up. And as you go further and further back in time, more ion channels, more sodium channels have had time to recover. So now you have relative refractory period, and then you have, obviously, it's resting and you can actually activate. Now, as the head, if the head of this gets faster and faster, remember, once you hit the orange, you're refractory. You cannot activate anymore. So that means if the head of this wavefront hits the tail, and the tail is orange during its refractory period, what happens? Refractoriness means you can't conduct. The circuit shorts out, the circuit dies, and the reentrant wavefront is gone. So one thing that you can do is if you improve conduction velocity of your wavehead, it is anti-arrhythmic. Higher conduction velocity is anti-arrhythmic because it's more likely that you're going to be fast enough for this arrowhead to hit the tail before the tail has had time to recover. So you hit the wavehead, hits the tail during its refractory period. Because the wavehead is going so fast, it hits the tail during refractory period, and the circuit is gone. Because it's refractory, it can't sustain itself. So improving conduction velocity is antiarrhythmic. Okay, next is the refractory period. If I make this refractory period longer and longer, and I make this tail longer and longer, right? If it takes longer for that action potential to reconstitute itself, for repolarization to occur again, then if that is the case, this tail becomes longer and longer, and you don't even need the wavehead to hit the tail. The tail itself, by prolonging refractory periods, eventually goes back, delays more, until the wavehead hits it, and the circuit shorts out. So improving conduction velocity is antiarrhythmic. That's one thing. And increasing refractory periods. By increasing refractory periods, you're making this orange tail longer and longer. That's also antiarrhythmic. Anything that's making the head kiss the tail is antiarrhythmic. Speed up the head, delay the tail. Increase conduction velocity, increase refractoriness. So, and this is just to show that length, when we're saying a wavelength, we're talking about the minimum circuit required to sustain this. So wavelength is a multiplication of your refractory period, which is time, times your conduction velocity. And what's velocity? It's distance over time. So time times distance over time is distance. So the refractory period times the velocity is the wavelength. So far in this talk, I've gone over 3 slides only, but these are the three most important slides. If you just understood what I told you in the last 3 slides, you will understand everything you need to know about antiarrhythmic drugs. And so let's do that. So now that we understand the action potential, now that we understand how you can be anti or pro-arrhythmic, now that we understand how these ion channels are working, now we can simply say, you tell me an agent, and you tell me which part of these areas, which areas in the action potential this agent is working, and I can tell you what it's going to do. I don't need to memorize names. I don't need to care about anything else. So that is what I'm trying to get at in the course of this talk. So I really don't want to focus on these somewhat, I think, arbitrary classifications. These are von Williams classifications, but I think it's important for us, for this purpose of this talk. Class 1 is sodium channel blockers. Class 2 are beta blockers. Class 3 is potassium blockers. Class 4 is the calcium channel blockers. This has been forever. Even when I was a fellow, this was a nomenclature. It has now changed, but on this talk, I don't want to focus on all the different changes. I just want to focus on the agents themselves. So it used to be class 1, 2, 3, 4. Now it's class 0, 1, 2, 3, 4, 5, 6, and 7. So again, who cares? Don't worry about that. You should, whatever, Von Williams, I don't care. I understand the action potential, and now you tell me I'm going to do something, and I'm going to tell you, Razavi, how that's going to affect. So let's play that game. Instead of focusing on antiarrhythmic drugs, let's together say, if I give you an agent, I tell you what it does on the action potential. Based on everything else that you know, you tell me how that, if it's antiarrhythmic, proarrhythmic, or not. So let's say we block the big sodium channel. You block the big sodium channel, we just discussed. Sodium channel, the slope of this phase 0 determines what? Conduction velocity, right? We talked about that. Phase 0, the slope in ventricular and atrial myocardial tissue, conduction velocity is determined by the slope of phase 0. So if I give a drug to affect phase 0, to block a sodium channel, what is that going to do to phase 0? It's going to truncate it. Phase 0 is going to take longer for the action potential to go up. The rate of increase slows down, and you have a slowing of actual depolarization, and your QRS gets a little bit wider too. But you have slowing of depolarization. Remember what? Slowing of conduction velocity. Did we just say that that's good or bad for the heart? Slowing of conduction velocity. If this head now, instead of speeding up, is slowing down, is it more likely that it's going to catch its head or less likely? Less likely. And if it's less likely to catch its head, that means the circuit is going to continue, correct? So therefore, anything that decreases conduction velocity is pro-arrhythmic. Be it drug, scar, I don't know, electrolyte derangement, anything like that. When you're blocking the sodium channel, you're sprinkling scar on the myocardium, okay? Because you're slowing down the conduction velocity. And that's why in these medicines, you have to have a normal, healthy heart, or else you can exacerbate and you can make the condition such that you have delayed conduction and you have more arrhythmias. And this is the reason why this group of medicines that blocks the sodium channel is contraindicated and has a black box warning for patients who have a history of a heart attack. Because you already have scar, and if you give these medicines, you're going to slow things down so much that now you can have these really slow, meandering circuits that, like, you know, a VT at 90 beats a minute. We've all seen those. So those are the drugged up, slow VTs, because you've slowed the conduction velocity, and it's just impossible for it to terminate. So that's essentially how the sodium channels, how the sodium channel blockers work. So if I tell you that, now I'm going to give you an example. I'll tell you that, say, for example, a drug named flecainide is a sodium channel blocker. You know exactly what, if you're going to use it, it's got to be a healthy heart. You can't have conduction delay. You can't have conduction system disease. You can't have a depressed EF that mimics scar that causes more delayed conduction, because this will exacerbate that slow conduction. So why even give it? How do the antiarrhythmics work? If you inhibit, at the end of the game, at the end of the day, cardiac stimulation. requires, contraction requires calcium influx. And anything that you do to inhibit the calcium influx makes it less likely that you're going to generate an action potential. And therefore, if you have an action potential that you don't want to deal with, that you want to erase, then in those situations, you can consider using a sodium channel blocker. And the classic example for those, PVCs, triggered atrial fibrillation, areas where just that calcium influx causes a single beat of arrhythmia, triggered arrhythmias, automatic arrhythmias, not as much automatic arrhythmias, but triggered arrhythmias can also be affected. Because when we think of triggered beats, I just said it's all calcium. So why a sodium blocker? Well, the sodium influx is what starts everything for the calcium to come inside. So when you're blocking sodium, you're blocking essentially the action potential and the contraction of the heart at that point. But you're also eliminating or decreasing the burden for triggered activity. In automatic cells, if we take this extension, and we're going to, in a second, I'm going to go to phase or class 0 medicines. But remember, we were just talking about this eye funny current. It turns out for pharmacological purposes, this and this current are very, very important. The calcium, the tiny calcium used to be blocked. There was a medicine that when I was a fellow, it was, and I think it was called, I forget the name actually, but it ended up being pro-arrhythmic. They took it off the market. But the eye funny current, this current, if you now block it, remember, this current leads to spontaneous depolarization, which means then spontaneous heartbeat. When you say depolarization, it's a spontaneous heartbeat. So if you eliminate this funny current, or if you affect it, then you're decreasing the rate of increase in this phase of the slope, in this of the slope in this part of the action potential phase, and therefore less likely to achieve triggered activity and another action potential. You just do not let this slope hit threshold, which is somewhere up top here. So by inhibiting this, this just stays flat. And this gives rise to the first class of antiarrhythmics, the so-called new class of class 0 von Williams antiarrhythmic drugs. And avabradine is the classic. We all know about avabradine, and it is a medicine that specifically works on the sinus node itself, and is actually really, really clean outside of that. It has very few other side effects, used for inappropriate sinus tachycardia, also for heart failure. How much time do I have? I just want to... Okay, good. We're going to keep going. So, without going here, so now, one of the things that's always confused people is we have sodium channel blockers, but some sodium channel blockers like lidocaine shorten your QT interval, interval. Others can actually prolong your QT interval. And why is that? So let's go back here. Remember what we said. So if you block the sodium channel, you're inhibiting phase 0, you're slowing down the conduction, your QRS is going to widen because as phase 0 is slowing down, then everything down here slows down, so your QRS widens too. So phase 0 QRS. What about your recovery? What about repolarization, the process where you're starting to go back down and you're dumping out that positive current? That's called repolarization, and that is initiated at the end of your QRS, the J point, and people call it your QT interval, but really it should be your J point to T interval. But this correlates with repolarization. And so if you block this process, then you're going to prolong repolarization. And what was this process consisting of? What's this going out? Potassium. So if you block potassium, you're going to prolong, it'll take longer for repolarization to occur here. This phase, it won't go down as quickly. It'll take longer and longer. And if this part gets longer, what does this part do? Your QT gets longer too. So any medicine that blocks the potassium channel has the potential to prolong your QT interval. And class 3 antiarrhythmics are potassium channel blockers. So again, you don't need to memorize class 3, whatever. I just tell you, I'm blocking the potassium channel, and you in your mind know I'm prolonging the action potential, making it the refractory period longer, and therefore, if I'm making the refractory period longer, is that proarrhythmic or antiarrhythmic now? I'm making the tail longer. That's right. That's antiarrhythmic because it's more likely now that for a given constant velocity of the head, if the tail takes longer to recover, the head is more likely to hit the tail before it is fully recovered, and it extinguishes itself. So speeding conduction velocity is antiarrhythmic, slowing conduction velocity is proarrhythmic, increasing your refractory period is antiarrhythmic, shortening your refractory period is proarrhythmic. Got it? All right, excellent. So now, this was the hardest part. So why is it that some class 1 drugs shorten your QT interval, others prolong it? Lidocaine shortens it, the rest of them pretty much prolong it. Well, it's because of the fact that these drugs are they don't necessarily bind to a specific ion channel. They are, for lack of, one drug can bind to multiple ion channels. And that's why you can have the difference in the physiological and the pharmacological effect. If you have a drug that blocks only if you have a drug that blocks only your potassium channels, you can prolong phase 3. If you have a drug that blocks sodium channels and blocks potassium channels, then you have a prolongation of the QRS, and you can have your QT prolonged, and we all know QT prolongation can be proarrhythmic. So the medicines in the past that were used, procainamide, quinidine, those are the class 1A agents. They will block the sodium channel, therefore they're class 1. But if they also, on top of that, block some of the potassium channels and make your action potential take longer for the cell to recover, then they can also have class 3 effects. And the reason, therefore, that you see this effect, it's not that there's something special about this class 1 agent that prolongs the QT, it's just that it also is a potassium channel blocker. So you already know that. You understand the mechanism of the action potential, and all I need to tell you is that there's a drug that blocks the sodium and the potassium channel, and you'll say, QRS will prolong, QT will prolong, it can be proarrhythmic for this reason and antiarrhythmic for that reason. Next drug, so flecainide, procainamide is this group. Next group, these are class 1B, lidocaine is the big one. What does that do? That blocks the sodium channel, but it also blocks a background sodium channel in addition to the first sodium channel that we saw. And there's this little background sodium channel that, here. You have a sodium channel that is always kind of in the background, leaking current inside. So if you leak current inside, is that more likely to maintain the action potential, or is it more likely to truncate the action potential? If you are inhibiting the outward flow of, if you're inhibiting the inward flow of sodium, you're going to shorten the action potential. Any time that current comes inside the cell, that's proarrhythmic, and any time current is not coming out or kicking out, that's antiarrhythmic. That's shortening the action potential. So that's what you would be doing if you're blocking that background sodium channel, because you're preventing leak of sodium, which is positive current, into the cell in the course of the action potential. So therefore, lidocaine blocks both sodium channels of phase 0 and the background, so it actually shortens the QT interval because you're inhibiting inward current in the form of the background sodium channel. And then you have the class 1C agents, which is actually what we're most familiar with. Propafenone, flecainide, I misspoke. Flecainide is a class 1C, quinidine is a class 1A. So flecainide and propafenone are class 1C agents, kind of intermediate in the strength of the binding of the sodium channel, but the big thing, propafenone is also a beta blocker. So beta blocker activity and sodium channel blocking activity. So share in common, class 1 antiarrhythmics, slowing of atrial ventricular conduction, and by slowing conduction, you hope that the circuit slows down enough to terminate, but you got to make sure new areas of abnormal and slowed conduction are not created, because that'll be proarrhythmic. I'm not going to get into this. My God, I'm almost out of time. All right, and so I just want to make one other important point. You have a phenomena of use dependence. In general, remember this, sodium channels are use dependent. The faster that you activate the heart, the more they bind the ion channels. Potassium channels are reverse use dependent. The slower you are, the more likely they bind the ion channels. So therefore, if you have a drug, a sodium channel blocker, it's probably going to be better to terminate an arrhythmia because the heart rate is going really fast and it's going to bind the drug will bind the ion channels more robustly. But if you have a reverse use dependent, that means it's a drug that binds more effectively when the heart rate is slow, then it's not going to be good for termination. It's going to be good for maintenance of normal rhythm, but not for termination, because termination, the heart's going fast. And if you're reverse use dependent, you're not going to bind the drug. The classic drug, reverse use dependent for this purpose, is sotalol. Sotalol is reverse use dependent. Most potassium channel blockers are reverse use dependent. And I'm sorry I went over time and I didn't get to talk about all the other drugs, but I really wanted you guys to understand how these drugs work at a more basic level. So thank you very much.